Our next talk is contemporary rates of inferior vena cava filter thrombosis and risk factors. And this is by Dr. King and colleagues out of the Medical University of South Carolina in Charleston.
My name is Ryan King. I'm a fourth-year vascular resident at the Medical University of South Carolina, and this is our study entitled Contemporary Rates of Inferior Vena Cava Filter Thrombosis and Risk Factors. Approximately 50,000 IVC filters are placed in the U.S. alone each year. IVC filter thrombosis can be a major source of patient morbidity, and it's an uncommon event ranging anywhere from 1 to 31%, but this is based off of older studies on older filters. We aim to 1. Describe the contemporary rates of filter thrombosis across multiple institutions. 2. Describe risk factors for IVC filter thrombosis in 1. All patients who receive the filter, and a subgroup of patients who received the filter in the setting of venous thromboembolism. In order to do this, we conducted a retrospective analysis using VQI data on filters placed between the years 2013 and 2019. Our exclusion criteria included cases without follow-up. The statistics we employed were relatively traditional, using log-rank tests and Kaplan-Meier curves, Mann-Whitney U tests, and Cox regression analyses to identify independent predictors of outcome. Looking at our cohort in total, there were about 13,000 cases of filters placed, and 6,000 of those had follow-up. Of those, there were approximately 4,100 cases of filters placed for VTE. That left about 1,600 cases in which filters were placed for an indication other than VTE, the majority of those patients without a hypercoagulable state. Looking at baseline characteristics of the cohort, there was about a 50-50 split between males and females within the cohort, the other demographic variables listed below. And there was a 26% of patients had a history of malignancy, 8% had a history of thrombophilia. For medications, approximately 25% of these patients were maintained on antiplatelet therapy during the pre-op period, discharge period, and at follow-up. For anticoagulation, 20% had anticoagulation in the pre-op period, and then about 50% had it during discharge and at follow-up. The indications for filter placement are here on the right, and procedural characteristics, there was a majority of temporary filters placed at 88%, the majority of course landing in the infrarenal IVC. At follow-up, there was a 63% retrieval rate that occurred with a retrieval time average of about 20 weeks. Looking at our outcome variable, the rate of IVC filter thrombosis, there were 78 identified cases for a 1.3% rate of IVC filter thrombosis among those who had follow-up. There were 9 risk factors for IVC filter thrombosis on univariable analysis listed here, including no antiplatelet therapy at follow-up, follow-up anticoagulation, new or propagated DVT at follow-up, internal jugular vein access, no pre-op statin, no coronary artery disease, VTE on admission, no diabetes, and temporary IVC filter placement. Our Cox regression analyses identified 5 predictors of outcome, including propagated or new lower extremity DVT at follow-up, no antiplatelet therapy, internal jugular venous access, VTE on admission, and temporary IVC filter placement. Interestingly, I'd like to point your attention to no follow-up antiplatelet, since it had a high hazard ratio of about 4.8 and was an unexpected finding. Similar factors were found to be independent predictors of outcome, including the lack of antiplatelet therapy at follow-up in those who had filters placed for the indication of VTE. In conclusion, this is a large contemporary analysis of international cases of IVC filter placement, and the rate of thrombosis is low, at approximately 1.3%. Temporary filters were independently associated with IVC filter thrombosis while controlling for other factors on multivariable analysis. Patients not on antiplatelet therapy at follow-up had an almost 4-fold increase of IVC filter thrombosis. These data support placing patients on antiplatelet therapy to prevent IVC filter thrombosis. However, this would need to be confirmed by prospective studies. Thank you.
Thank you, Dr. King. That was an excellent talk. There's one thing that both my co-moderator, Dr. Smeds, and I both noted, that next time if you do ever present at VESS, please go ahead and ditch the tie. That's very important to us. A steamboat hat or something similar is appropriate. but no tie. So first questions that I had, this is a very interesting study to taking a look because IVC filter complete thrombosis is relatively uncommon. But I guess my question is, how do you explain some of these findings? I mean, they're a little bit, I guess, non-traditional in a way, things like IJ axis or things like that. Do you think they're just associations, or is there something that is, about these factors that you discovered that we can actually change practice?
Yes, so I think a lot of these factors really highlights the high risk of a subgroup of patients that do get filters, namely those with VTE or that have issues with femoral access. So those who are getting filters through their IJ, my suspicion is it's not necessarily the placement of the filter through the IJ that puts these patients at risk. It's the subgroup of patients who need IJ access in order to get a filter placed versus femoral because they have lower extremity DVTs or chronic occlusions of their iliac veins, etc. So I think that explains some of the findings on our multivariable analysis that showed up. But certainly that includes anticoagulation at follow-up being a predictor of IVC filter thrombosis that I think highlights that VTE group. And that's why I think what's interesting is the antiplatelet therapy being kind of an unexpected finding. And I also think that comes into play when we looked at some of our univariable analyses where people with diabetes and people with coronary artery disease were actually found to have lower rates of filter thrombosis. And I think that's because a lot of those patients are being maintained on antiplatelet therapy. So that, I think that's one of the key findings of the study, but certainly the other ones are indicative of a high-risk subgroup.
What type of antiplatelets were they on? Was it just a baby aspirin, full aspirin, Plavix, Brilinta, anything like that? Were you able to break that down?
So the VQI data set allows me to break it down into aspirin and Plavix. Some of the other antiplatelet therapies that are used were not included in the field. When we looked at aspirin and Plavix, there was a slight association with decreased thrombosis on Plavix, but it was more profound in those who had aspirin.
I see. And as far as the antiplatelet thing goes, because traditionally antiplatelets are not associated with VTE prevention, obviously we use full anticoagulation. So do you think there's enough data here or any suggestion that we should start antiplatelets as well as anticoagulation?
I think that's a good question. And if you look at some of the prior data that is out there, a lot of it's limited on supporting antiplatelet for venous thromboembolism and prevention of recurrent venous thromboembolism. There is an INSPIRE trial that was done that did show a decreased rate of PE and DVTs in people that were maintained on antiplatelet therapy, but that was only in about 200 patient cohort. And I think looking at this data, the fact that it became a significant predictor in those who had a VTE and the cohort as a total, I think it is probably a good, at least one of the better pieces of literature that we can look at to support using antiplatelet for prevention of recurrent thrombosis.
Great question from the floor from Dr. Peter Nelson. Does the low thrombosis rate make us feel better about the fact that we still struggle with IVC filter retrieval? If I did the math right, as many as 75% of your total cohort or about 9,000 filters were not removed. Nice presentation.
Yeah, I think that the rate of thrombosis is still very low. So I don't necessarily think that it's going to impact the ability to retrieve the filter. And that's kind of just my feeling, just because the rate is so low. I don't know if it will have such a significant impact on that.
All right. Well, excellent presentation. Thank you. And I think we're going to move on.